Welcome. Welcome, welcome, welcome. we want to get started here and welcome all of you to Naples United Church of Christ. I'm Bob Nordland, a member here and also a member on the task force for Aging Well. And this started in 2016 when a number of members got together trying to address the issue of aging, and various issues came along like financial, cyber attacks, how to plan for end-of-life decision-making. But also at the time we had a lot of medical topics that people wanted. So at that time I was lucky enough to be able to go over to the NCH people here and dig up some speakers. And now it's much more formal, and it's a wonderful program that we can work together as co-sponsors of this program. And we're very, very pleased to have you. We're also co-sponsoring with the Alzheimer's Support Association, and they just had a talk just earlier this week and so on. So we're trying to keep up with things that people want to hear about, and this is certainly one of those that we do. So basically, I just wanted to introduce, we have Dr. Carlos Quintero, and a wonderful panel here, and I'm going to let him take over, and thank you very much. There'll be time for questions later on. It will pass mics and so on, but let's get started then. Thank you very much.
Great. Thank you, Bob. Welcome, everybody. So thank you for joining us for this exciting discussion on longevity. Great crowd today, so we're hoping to have some great conversations here a little bit about longevity with our experts that I'm going to introduce in a minute. So about NCH, I think many of you know we're transforming from Naples Community Hospital to Naples Comprehensive Health. So we're growing. I think a lot of you all have seen the growth, done some great work with our new leaders, our new CEO, or that's been CEO for the last few years, but we're partnering with the best. We've got partnerships now with HSS from New York, which is the top orthopedics hospital in the country. As many of you know, we have residency programs as well and some fellowships. We have endowed chairs. We have a fantastic simulation center. And recently we were named one of the top 50 hospitals in the country. So we're actually doing great things thanks to a lot of the speakers that are here with me today, plus the entire staff. So thank you all for that. So at NCH, we're proud to be a hospital built by the community and for the community. So we definitely want to give back and give you guys some time and give you guys the opportunity to ask us some questions. It's our mission to bring expert care and knowledge directly to you. So hopefully this will be very informative. I did want to introduce our panelists. I'm honored to be joined on stage by Dr. Gary Swain, who is concierge physician and former president of Collier County Medical Society. I don't know if, Gary, if you want to say a few other words about yourself, maybe how long you've been here or what else you do, what else you like to do with your time off.
I'm a board-certified family physician who has been living in Naples since 2013. Started off with a regular practice and kind of moved concierge about 3 or 4 years ago. I'm board-certified traditionally in family medicine, did a long faculty stint teaching medicine, and then eventually went back to do a fellowship in both academic medicine as well as functional medicine. So that's what I basically do now, so I'll turn it over to you.
Thanks, Gary. Dr. Carl Orringer, Director of Preventative Cardiology Program at NCH Rooney Heart Institute. So I'll let him say a few other words.
First of all, it's great to see you all today, and this is a tremendous group. We're excited about talking to you about what is new in terms of prevention of cardiovascular disease, and that includes prevention of heart attack, stroke, and leg artery blockage that can lead to amputation. And we're very excited about new approaches that we can take to keep everyone well. And it's not just maximizing longevity, which we do, by the way, but it also is what we can do when you get into trouble to improve the quality of your life. So I'm really excited to be with you. I've had a long academic career in cardiology and have also had been very involved with national organizations and writing the guidelines that our doctors use to treat high cholesterol in the United States. So it's a pleasure to be with you today.
Thank you, Carl. And Dr. David Backstein, Medical Director of HSS at NCH.
Thanks, Carlos, and thanks for having me here today. My background is orthopedic surgery. My fellowship was in hip and knee replacement. That's been my focus, and really for the past 15 years, even more just focused on knee replacement and redo of hip and knee replacements that have failed or need to be redone for one reason or another. And Indirectly, I think orthopedics is a big contributor to longevity, and I look forward to discussing it.
Thank you, David. And then a little bit about myself. I'm a hospitalist by training, so if you've been in the hospital, you may know what a hospitalist is. I'm internal medicine trained. I work seeing patients in the hospital, plus my other administrative roles. I work with all of these physicians taking care of patients as well as the rest of the staff. I've been here 18 years, quite a long time, and I really enjoy everything that has to do with inpatient, hospital, patient experience, quality, operations in the hospital. So very, very happy to be here. Thanks. So I wanted to kick us off here. First question, what we're going to do is we're going to pose some questions to the team here, and then at the end we'll have about 15 or 20 minutes where you guys can bring up some questions as well. Just want to let you all know. So first topic we wanted to talk about was how do lifestyle factors contribute to both cognitive and cardiovascular health, and what role does early intervention play in longevity?
So I distinctly heard that question was directed to me. So what I think I'm going to do is, first of all, tell you that it is really not particularly complicated to know what to do to live a long and healthy life. The first thing is, if you want to live a long life, it's nice to have some good genetics. And we really don't have the ability to change that. But because we all have certain genetic longevity built into us, we would like to do what we can to maximize the quality around that longevity. And based upon a number of the treatments that we use today for prevention, we actually can increase the duration of life significantly. People who used to be felt to have serious heart troubles that you knew they were going downhill quickly now live for long periods of time. We take patients who have heart failure and we can turn that course around so that they live much better lives and longer lives. Patients who want to protect themselves from that first event, we know what to do, and usually that revolves around, first of all, the fuels you put into your body. So we like to think about the Mediterranean diet as a great place to start, so that's whole grains as the basis of that. You'd like to use fresh vegetables, legumes, low-fat dairy products, and fish, olive oil, and then minimize meats, particularly processed meats, sweets of all types, candies, cookies, taking away all the great things. Doc, what are you trying to do to me? But it's not to say you can't ever have those things. It's just getting a focus on balance, and balance is everything that really tells you what you need to do to be successful. Exercise is such an important part of that, and regular aerobic and musculoskeletal exercise. And for maintenance, we usually like to think of 150 minutes a week, 150. So that would be 30 minutes 5 days a week. And if you want to do more, that's fine. You don't have to get into the high intensity stuff, because in fact, the older we get, the more likely we are to get injured when we try to get into high intensity exercise. So moderate intensity exercise is terrific. And then you need to keep your brain active. So you need to be thinking of things that are going to keep you mentally active. You got to read, you got to attend lectures, you got to listen to podcasts, whatever it takes to keep that brain going. It's going to really help you age in a more effective way. And finally, all of us have medical issues that we get to. And so when that happens, you really need to be careful to choose a physician who is up to date, someone who knows the latest treatments, has a lot of clinical experience, and people really need to relate to their doctor. But remember, sometimes you have a nice doctor who doesn't know anything. So you've got to make sure that not only do you have a physician who is up to date, somebody who knows the current treatments, but also someone who maintains their ties to learning and teaching others about the most important things in their specialty.
Thank you, Carl. What about on the orthopedics world? Diet, exercise, how does that influence how we take care of our joints before they get to you, Dr. Backstein, and having a knee replacement or a hip replacement? Does the same apply for joints, and what can the community and our patients do to try to help prolong the life of our joints?
Like the most common form of arthritis is osteoarthritis. It's, for the most part, probably genetically programmed to happen. You certainly can maintain joint health by keeping mobility, joint muscle strength, There's no real evidence that any of the preventive measures like glucosamine or any of the medications you might buy at Costco are going to prolong your joint health. Certainly, we see people that are both former athletes that get osteoarthritis of their hips and knees, but we also see plenty of people who have obesity and don't really have never had a very active lifestyle. So it's not, I hear all the time, I used to be a marathon runner, that's how I got osteoarthritis. Well, it's probably not completely true unless you have a distinct injury like a meniscal tear, a fracture. For the most part, people get arthritis because of just wear and tear and pre-programming for their cartilage cells to die over time. And cartilage cells don't regenerate, they're like brain tissue. Once they're gone, they're gone. So, I mean, I think for the most part, we know that obesity can contribute to joint pain. And one of the first non-operative measures for someone who has osteoarthritis of the knee or hip is an instruction to try and lose weight. Oftentimes, I recognize that that's easier said than done. Most people will have lost weight if they have a weight problem before they turn 70 or 75. So, it's an option. It's certainly beneficial for many reasons, not just your joints, but it's probably not going to be the ultimate solution. But by the treatment methods we have, we can then contribute to these other factors that can help you live longer. So if you have a very painful arthritic joint, you're probably not walking, the 30, 50 minutes a day. If we can get rid of that pain, you can get back to being active and maintain your heart and your brain and so on. It has chronic pain has a negative impact on inflammation, on your mental, happiness level, and we all know that has a role to play. So getting rid of the pain probably helps in that regard as well. So I think for most of the joint replacement operations for osteoarthritis, there's not a lot we can do to prevent it, but once you've got the problem, we have very good solutions that can then indirectly help with longevity.
So before getting to Dr. Swain, really quick question. You do a lot of surgeries for joints.
Yeah.
How important is it for our patients, and many of which may be here, before they go for the surgery, how important is it for them to be on the right diet and doing exercise before their surgeries? Does that help in outcomes?
No, there's no question. We know this better now than ever, that preoperative nutrition has an impact on wound healing, recovery time. There's an entire industry now of preoperative supplementation, where these companies will send you a box full of stuff for you to eat before and after the operation, because it's making sure you're getting those basic nutrients, protein that you need for wound healing and for recovery. So there's no question around the time of surgery, nutrition has a factor. More and more, we're also learning that a lot of complications like joint replacement infections that can happen years after surgery until now, we would often think, well, they must have had a tooth that was decayed or a urinary tract infection. Oftentimes the patients would deny having that, and more we're realizing it does have to do with nutrition, something called leaky gut, where if you have inadequate of the right bacteria in your gut, bacteria can escape, get into your bloodstream, and then seed out to your joint replacement. So there's no question that around the time of surgery, nutrition is important, and even further down the road, it probably can help prevent complications.
Thank you. So talking a little bit about brain, we've talked about heart, we've talked about joints. Gary, any thoughts on lifestyle changes that may help us stay sharp into our 90s and 100s?
You may have noticed that Dr. Quintero asked that first question of me, and Dr. Orringer stole it. Did you see that? And he stole it because he knew that he and I are going to say roughly the same thing. So it'll look like I'm copying him. But we know from several studies in Finland called the finger studies that are now being done in 39 other countries that we can delay or reduce the decline in Alzheimer's through certain lifestyle changes. Now, we're constantly coming up with new meds. We've got 2 new meds recently in the last 2 years that we use to dissolve beta amyloid in the brain. But even that has serious complications, because a lot of these drugs will have a risk of causing brain bleeds up to 30%. And the reduction that you get is a 30% decline, not an improvement. And so there was a doctor that was a functional medicine doctor. He was a neurologist who took his patients and started doing functional medicine training with them. And he wanted to do a big study on this, but The problem was he had 39 different variables that he wanted to test in his study, and the institutional review board said, no, that's too much. You'll not be able to, you can't power it strong enough to make. But even in people that we know have the genetic predisposition, not everybody develops Alzheimer's. So it's not just a genetic predisposition, but it's genetics plus some environmental exposures. And some of the environmental exposures include the type of food that you eat. So some people have even called Alzheimer's type 3 diabetes because it's much more common in people that have insulin resistance or elevated glucose levels or diabetes. We know that obesity is a high risk factor for this too, because it can increase inflammatory markers that can affect multiple things. 12 different cancers are associated with obesity. So when Dr. Orringer talked about the fact that you should be exercising regularly, they showed a 29% reduction in Alzheimer's in people that exercise 150 minutes a week. So that's kind of good. And that exercise could be brisk walking. It doesn't have to be anything strong. I normally talk my patients into doing a little bit of light resistance training 3 days a week as well, just to keep their muscles strong. I tell them that they need to socialize, just like Dr. Orringer brought up. So the things that go out and fix the heart are also very effective for the brain. And so being an active member of a church has been shown to be very effective in decreasing Alzheimer's. One of the tools that I talk my patients into trying is something called Brain HQ, which is an app you can download to your iPad. And they showed in a group of people that if they did some of the exercises within Brain HQ, that they would see a 20-some-odd% reduction in development from mild cognitive impairment onto Alzheimer's. And so a lot of my patients will do that. Socialization is very important, getting around people. So those are the big things I can recommend, is to watch your diet, get your exercise, get 7 to 8 hours of sleep a night, and to be around other people.
Great, thank you. I'm learning quite a bit here as well. So with the rise of minimally invasive and robotic-assisted surgeries, right, there's a lot of that we're hearing about. How do advancements in medical technology impact the longevity and quality of life of aging populations? Dr. Backstein, to start with you.
Sure. So, you know, in orthopedics, the advancements have really been incremental and broad-based. I can't say that a robot is going to change your longevity. In fact, robots are probably a misnomer in orthopedics. They're certainly not in other specialties like general surgery and urology, where, you know, the surgery has really completely had a paradigm shift because of these devices. In orthopedics, they're essentially a map. They're like GPS in your car. It'll show you how you get there, but you still have to know where you're going. If you put in the wrong information, you're not going to end up at the birthday party. You might end up, you know, somewhere else that you're trying to get to, because you still have to have a target. Part of that's where the surgical experience comes in. That's what we're still developing, to be quite honest. Nobody knows exactly what those targets are. But with those tools, whatever we choose, we're going to pretty much hit it. We just don't know if what we're hitting is the right thing quite yet. We've also had a lot of development in minimally invasive surgery. And again, you know, I think there's this thinking that it's, you know, some new technology that's been developed that's revolutionized. It's not really. It's just changing. For instance, around the hip, you may have heard about the anterior approach to the hip. All that is going through the front rather than going through the back or the side. The front of the hip has existed as long as the front as the side and the back. We just started using a different interval, what we call muscular interval, so that we don't have to damage as many structures to get into that hole. But it's not like this was just invented. That approach has been used for generations on pediatrics and other specialties. So we've just been adding up these incremental benefits over the years. I would also say, just to, you know, give anesthesiologists a little bit of the sunshine here, is one of the biggest probably breakthroughs in the way we do joint replacements nowadays is due to anesthesiology improvements. So spinal anesthetics, nerve blocks, medications to prevent nausea and vomiting. Those probably have had at least as much impact as the actual technique of the operation or the actual implant itself. It used to be when I was training in the late 80s, early 90s, a patient would stay in the hospital for probably a week after a knee replacement. Nowadays, it's not 7 days, it can often be more like 7 hours. And it's not because of some drastic change in the way we do knee replacement. There's for sure, incremental little changes, but it's related to the anesthesiology more than anything. Pain, multimodal pain techniques so that patients have less pain, certainly have very much, almost no pain the first few days. Eventually it wears off, but by then we've got them at home, so we don't have to worry about getting them out of the hospital. So anesthesiology, orthopedics, technology, they've all come together. There's no one huge breakthrough that has changed the way orthopedics is done, but it's definitely changed drastically because of all these smaller measures.
So I was talking to Dr. Orringer earlier about, I talked to you briefly about our simulation center, and one of our colleagues who's a world-renowned imager for cardiology, and the team was creating a 3D image of a heart for a complex surgical procedure that was going to happen yesterday. Carl's not a surgeon, but what AI technologies do you use in your practice in preventative medicine for cardiac disease?
Technology and cardiology is on fire. That's the best way to describe it. The stuff that our group is doing now, you can't imagine was possible. For example, we have for years seen many patients with heart failure who have very leaky valves. We're now able to pinpoint exactly where the valve is leaking and how much it's leaking using non-invasive technologies. And now we have ways that without opening the heart, we can drastically reduce the leakiness of heart valves so that you turn a person's heart valve, which was terribly leaky, into one where there's just the most minimal, minute leak, and they leave the hospital the next day breathing like they haven't breathed in years. In addition, we now have the ability to replace heart valves without opening the chest. So, for example, we have a very large program to put in the aortic valve, which is the main outflow valve of the heart, using percutaneous techniques. That means through the skin rather than opening the chest. And we can take a narrowed heart valve, put a valve inside it, and open it up so that a person's heart now can get the blood out to the rest of the body. Another thing that we're doing in selected patients is the mitral valve, which is a valve that's kind of deep in the heart that takes blood back from the lungs to the left ventricle. That valve can sometimes get very narrowed, and we are actually able in certain selected patients to go in from the tip of the heart right in and replace the heart valve without opening the chest. So the rate of technological advance in our group is amazing. We also have world-class cardiac imagers who can actually see down to the millimeter the size of the valves, where valve leakiness occurs, the type of leakiness that's present, and then fix it. So it's very, very exciting. But what I find equally exciting is the applications of technology to actually personalizing cardiac risk reduction, because my focus is prevention of cardiovascular disease. So my job is to do everything I can to keep people away from needing all these techniques. And in fact, we now have, in addition to have much more accurate ways of predicting risk, we now have specialized imaging technologies that use artificial intelligence to help us not only to know how much plaque a person has in their arteries, but the type of plaque that they have. And once we know that type of plaque, we can determine if their plaque is the kind that's considered relatively low risk for proceeding to a heart attack, or one that's high risk. And in those cases where people have very high risk plaques, we're able to get patients on very, very effective heart disease prevention medication, in addition always to good diet and exercise, to drastically reduce the risk of a heart attack. So these are all very, very exciting technologies that we use every day in taking care of patients at NCH. And I must tell you that I've been at NCH since August of 2023, and for many, many years was involved with academic medicine, both at University of Miami, Case Western Reserve University, and University of Michigan. I can tell you that I have never seen a more impressive group of cardiologists than I am working with here at NCH. These are people who are highly trained, coming from the best institutions throughout the country. and who are expert at what they do. So it's a privilege for me to be a part of this group, and I'm happy that we're able to deliver this to our community.
Yeah, I think that stresses a great point, that it's the great physicians that we have, but we really have a great team, not just of nurses, but the rest of the support team really make sure that we're taking great care of our patients. That includes everybody. So thank you for those. I'm going to move on. I want to make sure there's enough time for questions from the audience a little bit later. What is the role for inflammation and aging-related diseases like dementia, heart disease, joint degeneration, and how can it be mitigated? Gary, you want to take a stab at that? You talked a little bit about inflammation earlier.
So inflammation comes from multiple causes. One of the bigger causes is obesity. So the more fat you have, the more inflammatory mediators you can make. Now, not everybody that's obese makes a large amount of inflammatory mediators, but we see a bunch. I had a patient who had significant heart disease, and his BMI was 31. And we started him on all of the appropriate medications for heart disease, but his CRP, which is a measure of inflammation, was 3.9. And now that should be less than 1, and he was 3.9. At that level, you actually think about adding another drug to prevent heart attacks. So I looked at him and I put him on a drug called semaglutide Ozempic, which made him lose some weight. And amazingly, his CRP dropped down to 1, just with that drug addition alone. And so he had also lost 30 pounds, which I cannot prove that the loss of the fat caused the reduction in his inflammation. But we know that adding Ozempic or semaglutide and Mounjaro, the other one that does diabetic control and weight loss, can actually reduce the heart attack risk by up to 20%. And at my last conference that I went to, which was the cardiovascular conference put on by our team, one of the speakers was talking about how semaglutide should be the next new drug. Everybody should be on it, basically, to prevent heart disease. It has its side effects, but it's something that we can manage pretty carefully if you do it with a medicine doctor taking care of it, rather than getting it from your hairdresser. Because there are hairdressers here that are trying to sell it, so it's kind of scary.
It's in the black market, I think.
Yeah?
It's in the black market.
Anyway, but yeah, from my standpoint, from the dementia side, inflammation is the key. We want to decrease inflammation as much as we can.
So Dr. Orringer, if I'm afraid of heart disease, should I go out and buy some Advil or put myself on steroids to help prevent heart disease? What about the role of inflammation in heart disease? What should we be worried about? What should we be doing?
All right, so what's very interesting is we can now very precisely, using some very simple technologies, determine how much plaque a person has. It's a coronary calcium scan, which takes 5 to 10 minutes. There's no IV involved. It's a very rapid CT scan that gives a patient about as much radiation as a mammogram, for example. It's very, very low in terms of radiation exposure, but it can tell you very accurately how much hard plaque you have in the arteries of your heart, and the more you have, the higher your risk. Now, plaque is very important, but the question is, what leads to heart attacks? And it usually relates to inflammation of plaque. And so how can one determine if there's inflammation of those plaques that will predispose you to a heart attack? Now, Dr. Swain mentioned C-reactive protein, or CRP, which is one way that we frequently look for inflammation. But there are now more refined technologies that are actually also using artificial intelligence that are now being used to define how much inflammation there is in the fat around the arteries that supply your heart. This has now been used in Europe and will soon be coming to the United States to help us to know very precisely which patients are actually at the highest risk. So inflammation plays a tremendous role in our cardiac prevention strategies. One thing I do want to mention before I'm finished on this is that the biggest area where we see inflammation causing problems is in people who have recurrent atrial fibrillation. As you may know, the heart can be encased in fat, and in fact there's what's called the pericardial fat pad that sits right up on top of the heart, and the heart's pacemaker sits just underneath that. So people who are carrying too much fat, those fat cells are secreting hormones that irritate the heart's pacemaker. And we know that one of the most effective ways to prevent recurrent atrial fibrillation is for a patient to lose weight. So weight loss is an important factor in preventing recurrent atrial fibrillation, and it's thought to be mediated primarily through inflammation.
Yeah, I would just, how all this stuff ties together so nicely now that we're, learning more and more. In the knee, behind the kneecap, or what attaches your kneecap to your tibia is the patellar tendon. Behind the patellar tendon, everybody has a big, what we call fat pad. It's the knee fat pad instead of the heart fat pad. And that's been studied and shown that it produces something called lecithin, which is now believed to help promote osteoarthritis of the knee. So more obese people have a bigger fat pad, which secretes more of this hormone, which can then lead to osteoarthritis. So, we're finding commonalities where we didn't really expect to find them.
Thank you, that's great. How can emerging biomarker testing and imaging technologies improve early detection and prevention strategies for age-related diseases? You want to take a stab at that one?
I'm sorry, I have to hear it again. That distracted me.
How can emerging biomarker testing, we talked a little bit about CRP and a few others, and imaging technologies improve early detection and prevention strategies for age-related diseases? We're doing any biomarkers for dementia testing?
I know, we're going to get into it. I'm going to say the controversy here. So I just recently did a series of Alzheimer's for my patients. And it started with they had to read a book, and then we all talked about the book afterwards. And the book was a book by Dr. Bredesen, and he's a functional medicine doctor that was talking about the functional medicine things that you could do to decrease Alzheimer's. But the other thing that they've come up with lately is some serum markers that would look whether you're laying down more beta amyloid in your brain or the tau protein that causes a lot of the damage to the neurons in the brain. So you can actually measure that in the bloodstream. There's a test called a beta amyloid 40-40 ratio. And as that declines, it says that you're more likely to be laying beta amyloid down in your brain. There's a p-tau 217 level that if that level is increasing, it says that you're probably having more tau put into your brain as well, which tends to be a precursor. Now we're seeing that these biomarkers occur up to 5 to 10 years before we start to see cognitive decline. And so in people that you're trying to get these very strong lifestyle changes out of, I suggested that maybe it was a good idea to test these levels, because it's much easier for me to say, hey, you need to give up your sweets, you need to give up your alcohol, you need to go on a fairly strict diet, give me exercise, be socialized. And you look at me and you say, that would totally destroy my lifestyle. And I'd say, yeah, but you're 5 years away from Alzheimer's, which scares you most. When I first moved here, we had a big lecture on healthy living in the golden years, and my patients have laughed at me since and said, what do you mean golden? But during that talk, I walked out and I said, okay, there's 3 diagnoses on the board. One of them is heart disease, one of them is cancer, and one of them is Alzheimer's. And I want you to raise your hand. You pick one of these that scares you the most. And I said, okay, how many people for cardiovascular disease? And a few people in the room raised their hand. I said, how many for cancer? A few more people raised their hand. When I said dementia, everybody in the room raised their hand. And I said, okay, well, let's take this a little deeper. How many people have had a cholesterol check or a cardio IQ, had a coronary artery calcium score or something else to monitor for your heart disease? And everybody raised their hand, every single person. And I said, okay, well, how many people have had a colonoscopy or a mammogram or a PSA check? Almost everybody in the room raised their hand. And I said, okay, how many people know what to do to lower your risk of dementia? Nobody raised their hand. And I said, so what you're telling me is the thing that scares you the most is the thing that you know the least about. And so that's when we started talking about prevention strategies for Alzheimer's. So there are biomarkers that can predict if you're starting to lay down beta amyloid in the brain. There's actually a PET scan now called the Amyvid PET scan that measures beta amyloid in the brain. They actually also have a tau protein PET scan as well, but that one's not approved by the FDA yet, so we can't do it. It's only in research centers. So a lot of the research doctors that are out there, the big academic people, say nobody should be doing these tests right now because we don't know what to do with them. And I tend to be a little contrary and say, excuse me, but I'm asking people to do major lifestyle changes. And it would be much easier for me if I could say, hey, look, you're on this pathway to develop something going on in your brain. You would be a little more willing to say, hey, maybe I don't need that Snickers bar, and maybe I should, eat some cruciferous vegetables instead. So that's my thought, is that we are having more and more things that we can do to predict the onset of Alzheimer's, just like Dr. Orringer's talking about the heart. He has multiple new tools for that as well. The other thing I wanted to say about Dr. Orringer's presentation is how many people have watched commercials and said that's just a marketing play, right? And so he talked about how awesome our new cardiology department is. And what I want to say is I'm a primary care doctor. I don't have any skin in this game. And I got to tell you that we have got an awesome cardiology department now as far as doing the new valve replacements. And I send my patients to them all the time, and they're doing very well. I mean, we're leading Florida for sure, and in some ways leading part of the nation in some of our structural heart programs here. So I just wanted you to be really proud and hear it from somebody that wasn't a cardiologist, because he's got some vested interest in his program. Anyway, thank you.
So,
I think, it's an interesting point. So, it's always interesting to know who has vested interests in what. One of the things that it's really good to know is if you can step back and be objective, if you can really look at things. And the reason I can make statements like this is because I've been at multiple different high-level academic centers in the United States as part of my professional voyage. It really is a privilege to be involved with these colleagues of mine, both in the subspecialty arena and in the primary care arena. I can also say, going back at Gary, the primary care doctors that I work with who frequently refer patients, I'm seeing amazing evaluations that I didn't see in primary care doctors in other locations. So there's a lot of really high quality medical care that people here in Naples have access to.
So Carl, along the lines of markers, we talked a little bit about imaging, and you talked about CRP. There's other markers that you use, but what about some of the basic ones like cholesterol? We hear a lot about low-fat diet. Maybe you can shed a little bit of light on cholesterol, what's good, what's bad?
So this is kind of what I live, eat, and breathe, this whole thing about assessing a person's risk. And the best and most important marker for cardiac risk is LDL cholesterol. It stands for low-density lipoprotein cholesterol. One of the most common myths that people come to my office with, and I have to debunk the myth generally about 6 or 7 times a day, is people say, well, I was told that since my HDL is high, everything is fine. And the answer is, if you take populations of people, populations with higher HDLs do tend to have lower risk, but you take any person out of that population, HDL does not predict risk in an individual. It's LDL where the risk is. So the lower your LDL, the lower your risk. And as a result, you need to have that checked, and you need to make sure that if you have risk for heart disease, or if you've already had a cardiovascular problem, that your LDL cholesterol is maintained at as low a level as possible. Our goals today for people who have no other risk factors that are just trying to maintain a healthy lifestyle is to have an LDL cholesterol less than 100. If you have any risk factors for heart disease, high blood pressure, diabetes, smoking, family history of early heart disease, hypertension, we'd like to see your LDL cholesterol less than 70. And if you've had heart attack, stent, bypass, angioplasty, stroke, leg artery problems, we like to see your LDL cholesterol less than 55. And in fact, there's no evidence that there is such a thing as too low an LDL cholesterol. I wrote a paper in the European Heart Journal that was published a couple of years ago, which explored the question, is there any LDL cholesterol that's too low? And the answer is, the lower your LDL cholesterol is, the better your heart attack risk is reduced. And in fact, the only signal of any potential harm with very, very low LDL cholesterols is that there's a slightly increased risk of cataracts, in which case you can get those fixed and keep your heart in good health.
What about dementia? I hear the too low cholesterol, is that going to cause dementia?
Yeah, in fact, so that's a great question. What about dementia? The answer is this has been carefully looked at, and there is no evidence that lowering your LDL cholesterol markedly increases the risk of dementia.
Thank you.
So how many people in the audience have heard that statins are bad for you? Cholesterol medicines are bad for you? Okay. So it's really pretty funny because when I see a patient come in with an elevated cholesterol to my practice as a primary care doctor, the first thing I do is I check their cholesterol and I talk to them about the various parts of the cholesterol. So if you do a standard cholesterol panel, you'll get a triglyceride level, you'll get an HDL, you'll get an LDL, and you'll get a total. If you do a more advanced test, you'll get something called an Lp(a) or lipoprotein A, and you'll get an apolipoprotein B, and you'll get a CRP. So when I do that, I look at the patient and I say, okay, so your cholesterol's high. You've got a cholesterol that has an LDL of 130. And I say, you know that to treat somebody with an LDL of 130 and no history of heart disease, no history of stroke, no cardiovascular risk factors, I have to treat 84 people to prevent one heart attack. And so at that point, I get something called a CT calcium score, which Dr. Orringer's already talked about. And if that CT calcium score shows that the calcium score is 0, I pull out page 43 of Dr. Orringer's article on lipids, and there's 4 graphs on it. And the first graph shows with a coronary artery calcium score of 0, that if you treat them with a statin or if you don't treat them with a statin, they have the same cardiovascular risk factor for the next 13 years. If it's between 1 and 100, there's not much difference for the first 3 years, and then they start to diverge with the people getting the cholesterol medicine being improved. If the calcium score is over 101 to 300, they diverge in a very large way very quickly. And I like to use, I've kind of stolen his page out of his article that he wrote, and it's in every one of my exam rooms, and all my patients laugh when they see it because I pull it up and I say, okay, look right here, this is you. Yours is 130, and your cardiovascular risk diverges almost immediately whether you're taking a cholesterol drug or not. So yeah, cholesterol drugs may cause muscle pain in less than 10% of people, and Dr. Orringer will tell you the exact number in a minute.
So this is great. I mean, I really appreciate this, and I really appreciate having addressed the question of people thinking that statins do bad things. In fact, statins are amazing life-changing medications and life-saving medications, but some people do have complaints, primarily muscle complaints related to statins. Now, if you have pain in your left elbow or in your toe or in your knee, that's not from the statin. But sometimes people have symmetrical pains in the thighs or in the upper arms that occurred within a few weeks of starting a statin and went away within a few weeks of stopping it. That is thought to be related to the statin, and it does occur in a few percent. But guess what? We have so many strategies to deal with that. We sometimes will switch to a different statin and a person feels fine. Sometimes we use a very low dose of a non-statin combined with a tiny dose of a statin. We're almost always able to figure out ways to help to markedly lower that LDL cholesterol and reduce cardiovascular risk. But it's very interesting that Dr. Swain mentioned the importance of kind of knowing that you actually have the disease we're trying to prevent. If you have coronary calcium that's documented on this very rapid scan, we then have a roadmap to know how intensively we need to provide preventive treatment to keep you out of trouble.
So I think that brings us to our last topic before opening it up. People hear the statins are bad. I think a lot of us think that statins should be in the water. But what are some of the biggest barriers to implementing preventative medicine strategies across different medical disciplines, and how can healthcare systems overcome them? We talked a little bit about the fear, maybe in fake news. What else?
When I first started talking here, one of the things I brought up was alcohol use. And at the time, which was 15 years ago, taking one alcoholic beverage a day was considered good, it would be okay for you. That's since been challenged, and they don't think that any alcohol is good for you, but certainly more than one a day is bad. Now, the problem is, they said, how much is one alcoholic beverage? And for wine, it would be 4 ounces, okay? Now, I don't know if any of you have gone to a restaurant lately and said, hey, I'd like to order a Cabernet Sauvignon, and the next question that comes out is, would you like a 6 ounce or a 9 ounce pour? And so I have my patients come to me and say, Gary, I only drink 2 glasses of wine a day. And my next question has to be, is it a 6 ounce or a 9 ounce pour? Because if it's a 9 ounce pour, that's 4 and some change as far as how many drinks they've taken, almost 5. So the joke that I did at my lecture, and this was a true stat at the time, it's 10 years ago, I don't know if it's still the stat or not, but Naples consumes more alcohol per capita than any college town in the United States. And you can think about that for a minute, and most of my patients will tell me they went out and golfed 9 holes, they had 2 beers on the golf course, then they hit the club and had a cocktail at the club while they were talking about how good they made that shot on the 9th hole. And then they go out to dinner and have 2 glasses of wine, and then they go home and have a nightcap before they go to bed. By the time you're done, that's like 6 or 7 drinks. And so alcohol is kind of a problem. We need to really think about how much alcohol we put through our lips. And I'm pretty sure Dr. Orringer will tell you that alcohol is one of the leading causes for AFib, too.
In fact, when we look at all the risk factors that cause atrial fibrillation, by the way, for those of you who are not familiar with that term, that means a very irregular heartbeat that's occurring because the upper chambers are beating in a non-symmetrical fashion. The upper chambers beat in a very, very erratic way. Atrial fibrillation is a very common heart rhythm disorder, but the one factor that accelerates atrial fibrillation is alcohol.
So one thing I wanted to just add from when I take care of patients in the hospital, I often will see post-operative total knees or total hips, and I will generally ask my patient, how often do you drink alcohol? And the answer that I usually get is socially. Well, what's my next question to that? Well, how much do you socialize? Because what do most of us do when we're retired, right? We socialize. So along those lines, it is true that we do have to be very careful with the alcohol because it can get a little bit out of control, and we will see it sometimes in the hospital. Some of our patients will go in alcohol withdrawals. They'll have 3 or 4 drinks a day, and inadvertently they're all of a sudden confused, and all of a sudden they're in the hospital for 5 days instead of 5 hours because they're going in through withdrawal. So anyways, I think that was a great point. Anything else that you all want to share about barriers for preventative health for our patients? I think one other thing that I would add that I think we do a very good job at is communication and using our electronic medical record, right? So if we're able to communicate, right, these are 4 different specialties. Dr. Swain's outpatient, I'm inpatient, Dr. Backstein orthopedics, cardiology. If we can't communicate with each other, then we can't take care of our patients. So one of the great things that we've done over the last couple of years is we've added Epic, our electronic medical record system, and that's really helped us a lot, not just with artificial intelligence and helping make sure that patients come in for their colonoscopies, come in for their appointments. It helps us communicate. We can actually chat, HIPAA compliant chat. We can chat, all 3 of us, regarding any of our patients, and we can all see each other's notes, including a lot of the physicians in the community and up north in other places around the country. So I think that's one of the barriers that I think a lot of places have is communication, something just as basic as communication. If we can't communicate with our colleagues about our patients and patients can't communicate with them, that's a barrier. So I think that's one of the things that we've done to counteract that was implementing Epic, which was a lot of work, but we're seeing a lot of it pay off. Gary, I think you wanted to say something.
I was going to say, to show that, I wanted to apologize. I think you probably noticed me touching my phone during this conversation that we've been having. And the reason I've been touching my phone is because I've had 4 messages sent to me from the emergency room in the last 10 minutes about something that I need to deal with when we're done. And I said, I'll be calling you in an hour. Relax, we'll be fine. But that's how good the communication is. They can get a hold of me 24/7.
Another great point about that is that, frequently, Gary may have a patient in his office, and there may be a question about that, And even in many cases, it doesn't have to turn out to be a formal consult. He'll ask me, Carl, what do you think about this? And we're back and forth while the patient's sitting in his office. So it really, really facilitates communication. I also ask patients to think about when they're going up north, do the hospitals that your doctors practice at up north, are they on Epic? Because what really helps is that when people go up north for the summer, we're still able to engage in their care when we have Epic access. So it's a tremendous asset in terms of patient care.
One point I would make about barriers is, it's frequent in our clinics for patients to say, well, I'm too old to have a hip or a knee replacement. The things you need to have for a hip or knee replacement is pain, an x-ray that shows you have arthritis, and general health that will let you get through the surgery. The number on your birth certificate is irrelevant. We see a lot of 50-year-olds that have had bypass surgery and are diabetic and obese, and they are much higher risk than a fit, active 88-year-old. It's not uncommon for us to operate on 88, 90. I've operated on people in their 90s that just fly through the operation because they're the type of people who have stayed active, have stayed fit, and are willing to, have surgery to maintain that. So that's the mentality that they have, and that's kept them active. So I wouldn't worry about the chronological age, it's more your physiological age.
One of the things I'm quite happy about with NCH is that we're starting to see us spread out and bring excellent people in. So one of the things we just brought in was HSS, and I don't know how many of you people know about HSS, but Hospital for Special Surgeries is one of the best orthopedic hospitals in the United States, and we're bringing in a branch of it here. And we're bringing in doctors from there to take over. So we're leading into a new world where we've got world-class orthopedists here at NCH, and I think we're going to see an awesome change as we move on. Same with the cardiovascular clinic. We brought, I didn't know there were so many subspecialties in cardiology. I always talked about the plumbers and the electricians, but now we've got a specialist that her whole job is to do reconstruction of the heart so we can see it virtually on the screen rather than in the chest. We've got people that deal with specific amyloid heart, which is something that is becoming more and more common. And I don't suspect it's more and more common. I suspect that we've brought in the right kind of people to recognize it has been here all along, and we haven't been treating it right. And so I think we're in a remarkable time now where the technology and the education at our hospital is improving immensely, and you're going to see great changes in the next 5 years.
So
we have amazing educational activities going on in our group. We have cardiology fellows. These are people who have completed their internal medicine training and are now becoming specialists, subspecialists in cardiology. And we interact with our fellows all the time. We have conferences for them literally every day of the week. And they interact with us not only in the clinics and in the hospital, but also we have teaching conferences for them so that they know what is new and what is current in our field. I just got back from the American College of Cardiology conference in Chicago, and we had 10 of our fellows there because they were presenting abstracts from research that they had done. So this is, when you talk about ways to increase the quality of what you do, remember that doctors who are involved with teaching programs really have to be up to date, have to know what they're doing, and that's one of the things we're very proud of at NCH.
one last thing before we open it up for questions, just to add with regards to barriers. NCH is nonprofit. We will take any patient. So one of the issues that there's a problem here is also access. Not every patient has insurance. So we will take care of patients when they come to the hospital, but one of the challenges that we have is what do we do about preventative care for those patients? So we'll often send them to our resident clinic, our internal medicine resident clinic. We have residents and another committee that goes out to the community to try to do health fairs, preventative medicine, and then we also try to partner with our community healthcare services teams, kind of like, so it's the Clínica Los Angeles is one. There's, I just went blank on the federally health qualified, Neighborhood Health Clinic is another one. and Immokalee, I just went blank, on Healthcare Network of Southwest Florida. We partner with them to make sure that we're taking care of our patients. They have primary care where they need it, and then they also have world-class care here in the hospital. The other thing that we're trying to do is we really want to make sure that the seasonal residents and other residents that live here stay here for their care, right? They don't have to travel to get world-class care from all of these folks that are here on the team. So I will open it up for questions. I think we have a mic in the back. We're about an hour, but we wanted to make sure that you all have a little bit of time to ask some questions to our experts.
This question is for the orthopedist. Can you tell me a little bit about the use of stem cells post-surgery, perhaps?
Stem cells have a use. They have been shown to be effective with chronic tendonitis, chronic tendon ruptures that aren't healing. They're being used a lot for treatment of arthritis. There's no scientific data to back that up. Having said that, a lot of people feel like their knee got better after they had stem cells. If you look at just true science for osteoarthritis, there's no proven benefit. But there are uses for it in certain types of orthopedic sports medicine, etc.
This is a general question about technology. Are you using, or is AI involved in any of the new technology or procedures you're using?
I'll take a stab at that just to start if you guys want to add anything to that. The answer is yes. AI is pretty much everywhere. It's going to come. We've got to learn how to use it. So within our electronic medical record, there's multiple ways how AI is used. One of the things that I've used it for is to help predict which patients are at higher risk of readmission in the hospital, for example. So we needed to wait for about 9 months, almost 12 months, for Epic to look at every single patient that came in through the hospital, risk factors, who was more likely to get readmitted to the hospital based on those risk factors. Now I can use that technology to target, hey, this patient is at higher risk of getting readmitted, say for congestive heart failure, for example. That's one instance. The other instance, which is slightly different, is I was actually visiting with one of our gastroenterologists a couple of weeks ago, and they use AI technology when they're doing their colonoscopies and endoscopies based on similar algorithms. When they're going through on the images, the monitor will alert them if something looks like a potential fold in the colon versus a polyp. So that it hints on the monitor, and it tells the physician, hey, this looks like a polyp. You may want to take a look and stop here. But AI is absolutely everywhere. We're all going to have to learn how to use it. Also to help us with our notes, we're starting to look at what ways can AI help us with ambient technology to help us with documentation. So that's another thing that we're looking at. You guys probably have other examples.
Yes, one of the newer blood tests that are out there is called a Gallery test. And the Gallery test looks via a blood test whether you have cell-free DNA in your blood. And that cell-free DNA is more common from cancer cells than from regular cells. You will always have some cell-free DNA, but if you have a certain level of it, then it says this is probably a cancer signal. And then they send the second tube over to an AI company that breaks it down and looks at the methylation patterns, meaning where are carbon atoms attached to that DNA, and it can tell you if that cell-free DNA is from a pancreatic cancer, for instance, or from an ovarian cancer. Now, it's not good for everything, and it's only got an 80% sensitivity at this time, meaning that if you have the cancer, we'll find it 80% of the time. But pancreatic cancer, we tend not to find until it's stage 4. So if I can find it in stage 1 or 2 with a Gallery test, that's kind of awesome. So that's one way we use AI. One of the other things is something that Dr. Orringer's already talked about. There's a way to do a CT angiogram of the heart and to look at the blood vessel's diameter in the heart. And they can send that off to an AI team called Clearly, and it can show me how narrow the artery is, and it can also tell me the flow, what's called the fractional flow rate, or how much the flow declines below the narrowing, which is kind of important, because if it doesn't really affect the flow, then you don't need to go have a stent necessarily. But if that fractional flow rate drops way off, then they say, this is a perfect candidate to go to the cath lab and get a stent placement to open up that artery. So we're using it. The other thing that they're doing is they actually have a computerized stethoscope that they're testing in some of the clinics now. And that stethoscope reads off to a iPad that'll tell you what the heart valves sound like and make sure that you don't miss an aortic stenosis or a mitral regurg that sometimes if you've been to too many rock concerts, you may not hear with your regular stethoscope.
A few other questions.
You spoke quite a bit about inflammation. I wonder if you would talk a bit about cortisol, what it is, and how we can control that.
So cortisol is made by the adrenal gland, and it's your natural cortisone. You've all heard of cortisone. And controlling it is kind of interesting because you want to make some, but you don't want to make too much. And there are functional medicine doctors that believe that there are herbal medicines or other medicines that can help calm your adrenal axis a little bit. But probably more important is to find things in your life that are relaxing, such as, I know this doesn't sound right, but exercise actually is a perfect way to lower high cortisol levels. If you exercise regularly, the cortisol levels tend to decline. Now, if you over-exercise, like Dr. Orringer brought up earlier, then the cortisol levels actually spike. So we want to have some exercise to kind of burn off the stress of the day. Cortisol is released when you're stressed, but it's also released when your sugar drops too low, so it's got multiple functions. As far as inflammation, I don't know that the cortisol level is going to affect you much one way or the other. But yeah, cortisol is something I have to deal with every day because people come in and say, I'm so exhausted. And so I'll try to check their cortisol level to make sure that they're not adrenally suppressed for one reason or another, because a low cortisol will make you exhausted and feel terrible. And then I have some people that their cortisol level is through the roof, and they have Cushing's syndrome, and I have to try to get that under control. And the one thing we need more of in Naples is endocrinologists. So if I had my way, we'd have 5 more endocrinologists in town to help with that.
I think there was
I'm going to apologize before I say this because we have such a brilliant group of people up there, and my question is so basic. We are in Naples part-time, want to become full-time. We're having trouble getting a doctor, and you hear about concierge doctors. Why should we have a concierge doctor to get us accessibility over a doctor that maybe can't get us accessibility to your treatment? Do you have any comment on that?
So I can take a little bit of a stab at that too, but
Okay.
do you want to start and then I'll
So
take it?
from my standpoint, you should not have to have a concierge doctor. There should be enough primary care doctors that there's primary care doctors available for you. And I'm almost embarrassed when I say that I'm a concierge doctor because I feel like I've sold out to the enemy. But I've been practicing 40 years and I'm tired. So this way I get to go from having 4,000 patients to 300 patients. And I get to spend an hour with each one of my patients. And several of my patients are in the room, and I think they would agree with that I get to spend more time with them. I get to spend more time educating them. And some of the more important things that I've done since I've been concierge is I spent much more time in education rather than just saying, here's your prescription, get out the door, your 7 minutes is up. So why would you want a concierge doctor? You get a little more time. You have somebody that doesn't have 5,000 patients seeing him. So they can give you a little more time, a little more personal sort of stuff. But you're right. There shouldn't be a need to see concierge doctors. You should be able to find a primary care doctor in town. And NCH is trying their hardest to increase our number of primary care doctors in town.
Yeah, and I think if you wanted to chat with me afterwards, I can try to help if you're trying to get some help getting a primary care doctor. But some of the things that we're doing, we're trying to improve the access, to your point, to make sure we have enough primary care doctors. There's concierge doctors and there's a lot of primary care doctors as well. That's one of the main reasons why 7 or 8 years ago when we decided to go ahead and start the residency program, we want to have more primary care presence, train our docs, and keep them in Collier County so there's more accessibility for patients like yourself. So if you needed to chat with somebody afterwards, I'm happy to help.
Can I put in a plug for HSS?
Yeah, of course.
So we're not primary care doctors, but we have just recruited 12 new orthopedic surgeons, not new in the sense that they're fresh out of school, but new to Naples, all experienced, and built a building that's designed specifically for efficiency in clinical care so we can see more patients, operate on more patients. So the capacity for orthopedics in Naples has just gone up tremendously.
And I would say the same thing for cardiology, which is one of the leading problems that everybody has in Naples. And we have increased our cardiologists by how many?
The thing that's amazing is the cardiologists who we have we literally, it looks like the Ivy League at NCH. So Harvard trained, I mean, the best hospitals, Brigham, Mass General, Duke, these are the people we have now at NCH. And so the quality of what you're going to get is going to be very special when you come here.
Hi there. I was curious to know what you may be thinking about the impact of the governmental firings and grants discontinuance, the impact on our hospital, and what will be done about it.
Do you want to try to be a little bit more specific about which ones, what areas specifically?
Well, of course, there's a lot of research, and there are grants, which I guess are connected to that, but I didn't know how much funding our hospital receives federally here.
A little bit on research. Do you guys want to take a stab at the research part, or no? I mean, I think most of our go ahead. I can try, but
yeah, I think fortunately we are in one of the most philanthropic and generous communities known to man, and a very large part of our research, and we have a very, very active research program in multiple areas, especially in the cardiology area. But we're very blessed to have tremendous philanthropy, which has supported a tremendous amount of our research. You're right that there is real concern, especially in academic medical centers, where a lot of the dollars that they're used to getting from federal sources are not going to be there. So that once again brings up the importance of philanthropy, and one of the things that's so exciting to us is that in the next, it'll be between 18 months and 24 months, we're going to be opening up a $250 million heart hospital at NCH. And this was largely, vast majority, supported by philanthropy. So I think as good as it is now, it's going to get even better then. So I think, and then the Hospital for Special Surgery, all of these are exciting new approaches. And fortunately, we are not as dependent on national philanthropy as many other hospital systems are.
And this is the reason why we're able to stay independent, is because of a lot of you all in the philanthropic support. We are in one of, I think it is the biggest philanthropic campaign across the country to try to help bring world-class care here to Naples. And I think the other, I'll plug in just a little bit along the lines of that question. A couple of people have asked, hey, what about the tariffs? Are the tariffs going to affect a lot of our supply chain and a lot of the construction and everything that we depend on at the hospital? And the answer is largely no, because most of our products are actually made in the United States. The few products that perhaps were coming from elsewhere, we actually stockpiled on them just in case. So thankfully, things like the tariffs probably not going to affect us very much. So I just wanted to answer a little bit on that line.
So I was told we have time for one more question. Their hand had gone up here.
Dr. Swain, I've spent a lot of time on college campuses in my 88 years. And since you've identified the acute crisis that we have with alcohol, could you give me an opinion on the no alcohol liquors and wines, if that is a good alteration to a diet? I've lost 60 pounds in a year and a half by getting off of alcohol.
I congratulate you on your weight loss, and I don't have enough data to say that the alcohol-free wines are better. Sometimes when they do things to manipulate products, like let's take milk, for instance. When you try to make it 2% or skim milk, you've changed it. And there's questions about whether you've changed it for the better or not. And I would say the same thing with alcohol. I don't have evidence that it's good or bad, but I really am glad that you've lost the weight. That's great. Keep doing that.
I think the only other thing that we have to watch for is what are these products made with, right? We're trying to supplement one with another, but if it's got a very high sugar or carbohydrate content, it's probably going to not be that good for you either. So you're switching one thing for the other. So I think we've got to be very, very careful with all these products that are out there that are being marketed to us. So I think that's just word of the wise, just be caution there. So
I just want to say, I know there'll be maybe individual questions after we all leave here, but we really, really want to thank you and give you a wonderful hand for the wonderful job you're doing. Our church really appreciates what you've done, and so do our co-sponsors, and we've worked well with you in the past. So thanks again for coming. We appreciate it.
thank you all. Thank you very much. Have a great afternoon.